Y bueno, en nuestra última plática programada para esta noche, hemos querido abordar un problema de salud asociado a VIH que encontramos cada vez con mayor frecuencia en nuestra práctica diaria. El tema es hígado graso, un nuevo problema en pacientes con VIH. Para eso hemos invitado a nuestro experto, el doctor Justin Bailey. El doctor Bailey estudió medicina en la Universidad Johns Hopkins con la especialidad en medicina interna e infectología en la misma entidad educativa. Es profesor asociado en medicina. Su principal interés clínico es el manejo y tratamiento de las hepatitis virales, incluyendo la hepatitis C. Su interés en investigación incluye el estudio de la respuesta inmunológica contra el virus de la hepatitis C, en particular la respuesta por anticuerpos neutralizantes con la meta de desarrollar una vacuna contra el virus. Muchas gracias por acompañarnos, doctor Bailey. Muchas gracias por acompañarnos. Y estamos listos para su plática.
Thank you very much for the introduction and for the invitation to speak. Like Dr. Flexner, I'm sorry that I am not physically there with you in Mexico, but happy nevertheless to be able to talk. So I am going to talk in this talk about fatty liver disease, which is a very clinically important problem that I and probably many of you experience. And as was mentioned on Saturday, I'll talk about my true passion, which is hepatitis C vaccine development. So no relevant disclosures. So my goals today are to just define the problem of non-alcoholic fatty liver disease in people living with HIV, to talk about current management guidelines, and then also to talk a little bit about future directions for management of this very important disease. So I'm going to start with a case presentation. So my clinic in Baltimore is primarily patients with HIV and hepatitis C co-infection. Many of those patients now have been treated for hepatitis C, and their hep C is cured. But what we've noticed is that despite having their hep C cured, some of these patients continue to have a persistent abnormal ALT and AST liver enzymes. So this is a case presentation of one of those patients. So this is a 55-year-old man with HIV that has persistently abnormal liver enzymes despite having been cured of HCV. And that's been going on over the course of multiple tests for about 2 years. He did have HCV for many years, more than a decade, but was cured 2 years ago with sofosbuvir and ledipasvir. His pre-treatment FibroScan test had a score of 10.8 kilopascals. So significant fibrosis prior to treatment. That's consistent with F2 to 3 fibrosis. His HIV has been well controlled for a long time on efavirenz, tenofovir, and emtricitabine. In terms of labs, his HIV viral load is undetectable. His hepatitis C viral load, fortunately, is still undetectable. But ALT and AST are both slightly elevated, and bilirubin also is slightly elevated above normal. So we got a right upper quadrant ultrasound, which showed increased echogenicity, which was described as consistent with either fat or chronic liver disease, which of course we already know that he has chronic liver disease. So the question is, unfortunately you all can't vote here, but you can think for yourselves. The question is, what would you do next? A, order a CAT scan of the abdomen. B, repeat the FibroScan test, this time with CAP, which stands for Controlled Attenuation Parameter. C, order an MRI with PDFF, that stands for Proton Density Fat Fraction. Request a liver biopsy, or refer to hepatology. As I mentioned, I'm an ID doctor, not a hepatologist. So we'll get back to those questions and talk about what are the right answers toward the end of the talk. So I want to talk a little bit first about how common is fatty liver disease and how common is NASH, which is fatty liver disease with hepatitis. And the answer is they are very common. So in the general population, what is shown here, about 25% of people have fatty liver disease. And of those folks who have fatty liver disease, about 25% have NASH, have hepatitis associated with that fatty liver. The problem is even worse in people living with HIV. So in people living with HIV, about 35% of people have fatty liver disease. And of those people with fatty liver, about 42% have associated hepatitis. So a big problem in the general population and an even bigger problem in people living with HIV. So this is just a slide showing the many studies, some of the many studies that have been done to look at prevalence of fatty liver in people living with HIV. You can see that there's quite a range of estimates of the prevalence from 9% all the way up to 60%. And you'll also see that multiple different modalities were used to diagnose fatty liver. Some probably more accurate than others. But what's consistent across all of these studies is that the prevalence of this disease is quite high. So let me take a step back and just better define what is non-alcoholic fatty liver disease. So it is a continuum that starts with infiltration of fat into the liver, which is what's shown on this slide. And at that stage, you just have steatosis or fat. Once you get infiltration of inflammatory cells into the liver along with the fat, which is shown here, these are lymphocytes, that's when you start to develop hepatitis, inflammation in the liver. And that's when steatosis becomes NASH. Once you've had NASH for a significant period of time, you start to get deposition of collagen in the liver along with the inflammation. This is fibrosis that's developing along with the NASH. And those of you who are familiar with hepatitis C, probably most of you know that this is really the same progression that we see over time with chronic hepatitis C. The difference is the inciting factor here is fat in the liver, as opposed to replicating virus in the case of chronic hepatitis C. But this chronic course with accumulation of fibrosis is very similar. A key takeaway that I want everyone to realize is on this slide. It's that NASH itself is reversible. The inflammation and fatty infiltration in the liver is reversible. But fibrosis, for the most part, in particular advanced fibrosis that eventually can result, is not reversible. So again, just like chronic hepatitis C, our goal with NASH should be to try to reverse the inflammation before patients have a chance to develop advanced fibrosis. So again, this slide is showing the progression of disease from healthy liver to fatty infiltration to fat accumulation with inflammation, which is where you start to call this NASH, and then finally fibrosis. And then here is the undesired outcome, which is cirrhosis, where you have significant fibrosis, by definition F4 on the Medivir scale. And this is where you start to develop increased risk of hepatocellular carcinoma, HCC, also increased risk of end-stage liver disease and death as a result of this disease. So the key risk factor for development of NASH are metabolic abnormalities. So that is a very broad category of risk factors, but specifically it includes diabetes, obesity, high triglycerides, and importantly, for people living with HIV, it also can include medication toxicity. So in particular, some old NRTIs that we really don't use anymore had metabolic effects, but also efavirenz, an NNRTI, also has some mitochondrial toxicity and has been associated with increased risk of NASH. We know that protease inhibitors also can have some metabolic toxicity, some effects on lipids, also can have some hepatic toxicity. So protease inhibitors also have some association with NASH. An open question still is the risk of NASH associated with integrase inhibitors. So, we've all talked a lot and heard a lot over the past few years about the risk of weight gain with integrase inhibitors. And so, of course, it's logical to wonder whether they're also associated with increased risk of NASH. For the most part, the studies so far are not showing a significant association, fortunately. And I'll get a little bit into why I think that is as we talk more about specific risk factors for NASH. So this is a study by Cron et al. That again highlights the association between NASH or fatty liver disease and metabolic disease in general. So what this shows is that there is an increased risk. Sorry, I need to move this. What this shows is that there's an increased risk of diabetes, which is shown here in orange in people that have fatty liver disease. There's an increased risk of hypertension. There's an increased risk of dyslipidemia in people with fatty liver disease. And when we talk about fibrosis, again, there's an increase in people who have fatty liver disease with fibrosis. They also have increased risk of diabetes, increased risk of hypertension, dyslipidemia, and in addition, increased risk of chronic kidney disease. So how do we diagnose NASH? This is a really important question since it's such a common disease. First of all, you probably need a clinical suspicion, and that generally comes from laboratory findings. The serum liver enzymes, AST and ALT, in particular ALT, tend to be slightly elevated, about 2 to 4-fold above the upper limit of normal. AST to ALT ratio is usually less than 1. So this is one way that you can get a sense of whether this is more alcoholic hepatitis versus non-alcoholic. ALK-Phos tends to be around normal, slightly elevated. Ferritin tends to be a little bit elevated. Albumin, bilirubin, INR, all for the most part are usually normal until a patient reaches end stage or late cirrhosis. So liver biopsy is the gold standard for diagnosis of NASH. And liver biopsy is really the only test that gives you all of the information that you might possibly want about NASH, because It tells you about steatosis, which is how much fat is there in the liver. It tells you about inflammation. It tells you how much ballooning and degeneration there is of hepatocytes. Those three things together give you an NAS score and allow you to make a formal diagnosis of either fatty liver disease, steatosis, or NASH. So it allows you to differentiate just fatty infiltration versus NASH. Of course, liver biopsy also gives you a fibrosis score, which generally we use a Medivir scale from 1 to 4. Now, nobody really likes liver biopsies, especially patients. So, of course, we prefer to use non-invasive tests when we can to make a presumptive diagnosis of fatty liver disease. This is a study by Lemoine et al. In 2018 of 140 patients, where they used liver biopsy as a gold standard, and then looked in particular at MRI with the PDFF or FibroScan with CAP to see whether they saw agreement between those tests and liver biopsy in the diagnosis of fatty liver. And they actually saw a very good agreement. So for both tests, the area under the receiver operating curve was very good, either 0.87 or 0.98. So the takeaway here is that FibroScan with CAP or MRI with PDFF are a very good substitute for liver biopsy in diagnosing fatty liver. Again, the thing I'll point out is what you're missing here is you don't know whether that fatty liver is accompanied by inflammation and hepatic ballooning like you do if you have a liver biopsy. So it still is a little bit unclear after a FibroScan, for example, whether the patient actually has NASH or if they just have steatosis. Now, if you see elevated ALT with no alternative explanation along with steatosis, then generally we will make a presumptive diagnosis of NASH without necessarily needing a liver biopsy. Now, of course, a FibroScan, in addition to giving you a steatosis measurement based on the CAP score, also is pretty good at giving you a fibrosis stage. So this is, of course, also a very important thing to know in a patient where you suspect fatty liver, whether their NASH has progressed all the way to a fibrotic stage. And in particular, FibroScan is very reliable in ruling out advanced fibrosis. And usually FibroScan score greater than 12 kilopascals would indicate advanced fibrosis. There are biomarkers from blood tests that we can use as proxies. Now, these are even more limited than FibroScan or MRI. They really just tell you fibrosis stage. They don't tell you whether there's fatty infiltration of the liver or not, and they certainly don't tell you whether there's fatty infiltration with inflammation in the liver. Really, they're just giving you a fibrosis score. But they actually are relatively good at that part about giving you the fibrosis score. And in particular, we pretty commonly use FIB4 or APRI when we're not able to get a FibroScan test quickly in a patient to know how much fibrosis they probably have. So we've talked a little bit about risk factors for NASH, but I'm going to talk now more specifically about some risk factors. So first of all, in the general population, what are the things that are risks for fatty liver disease? And this study by Pang et al. In Nature last year showed that both BMI and waist circumference were significantly associated with increased risk of fatty liver disease in the general population. They did see a slightly stronger association between waist circumference with fatty liver disease than they did with BMI. Now, even more specifically than waist circumference, you can get a measurement called VAT, which is an area of visceral adipose tissue. And this is something that you would measure using a CT scan, a CAT scan. And this study by Yu et al. In 2015 showed that in the general population, increasing VAT was associated with increased risk of NASH, and it also was associated with increased risk of NASH with significant fibrosis. So once you get up to a VAT measurement of around 200, you have that patient has a significantly increased risk of both NASH and significant fibrosis. So what about specifically in people living with HIV? What are the risk factors, or what are the most accurate risk factors? So this is a study by Giraldi et al. In 2008. And in a univariate analysis, they saw an association between both BMI and waist circumference with increased risk of fatty liver disease, and increased risk of severe fatty liver disease. But once they looked at multivariate analysis, it was actually waist circumference and not BMI that was significantly associated with increased risk. And getting back to visceral adipose tissue now, specifically in people living with HIV, here on the y-axis is area of visceral fat. And you can see that there's a significantly increased risk of fibrosis in people with fatty liver if they have higher visceral fat. And here is BMI. You can see that there's no significant difference between people with no fibrosis and fibrosis based upon their BMI. So again, it's looking like visceral adipose tissue is a better predictor of risk of fatty liver, including in people living with HIV, also a better predictor of risk of fibrosis. So this is a study by Foreman et al. That just came out this year that I'm going to talk about a little bit. And they looked at a lot of correlates of liver fibrosis, specifically in people living with HIV who have fatty liver disease. First of all, I'll point out, again, they showed that visceral fat area was significantly associated with baseline fibrosis. Not surprisingly, they also saw that ALT and AST, liver enzymes, when they're elevated, also associated with fibrosis. In terms of HIV-specific indices, they saw that NNRTI use, I mentioned efavirenz earlier. NNRTI use was significantly associated with increased risk of baseline fibrosis. And getting back to that question of integrase inhibitors were not, use of integrase inhibitors was not associated with increased risk of baseline fibrosis in people with fatty liver. So here's another really important slide that I want to focus on. And it's very important to remember that people with HIV have more rapid progression of fibrosis when they have chronic inflammations in their livers. So we've known this for a while with chronic hepatitis C, that people with HIV, their fibrosis progresses more quickly than people in the general population. And it turns out that's also true for fatty liver disease. So this is a study, this is an unpublished study so far, again by Foreman et al., where they looked at rate of progression of fibrosis in people with fatty liver disease. And they actually compared, most of the people in the study did not have HIV, but they had a sub-analysis of the 24 people who were HIV infected in the study. And 38% of those people progressed an entire stage of fibrosis over the course of 12 months. So on average, the mean rate of fibrosis progression in the study in the people living with HIV was 0.2 stages per year. In the general population, it was only 0.03 stages per year. So the rate of progression of the people with HIV, all of these folks had fatty liver disease to start with, but the rate of progression of the people with HIV was much faster. So I bring this up just to make the point that the stakes are really quite high in people with HIV in terms of trying to reduce or reverse NASH before they have time to develop significant fibrosis. And again, I showed that VAT was associated with risk of baseline fibrosis in people with fatty liver. It also, in this study, was associated with risk of progression of fibrosis. So people with more visceral fat had an increased risk of progression of their fibrosis over time during this study. So how can we manage NASH? This is actually the really hard part, okay? So far and away, the most important management for NASH is lifestyle intervention. So there have been many studies of NASH in people with and without HIV that showed that weight loss can reverse NASH, can improve liver enzymes, can reduce liver inflammation. In general, across most of these studies, if you get about 5% weight loss, 5% of body weight lost, you start to see loss of fat in the liver. And if you start to see, if you get up to 10% weight loss, you actually start to see reversal or loss of inflammation in the liver, which is what you really want. Now, of course, a lot of people have trouble losing 10% of their body weight, especially if they're obese to begin with, just through dieting. And so bariatric surgery is an option to consider in obese patients that have advanced NASH, possibly with advanced fibrosis. But there are not a lot of big studies showing the long-term effects of this. I'll show you a study in a minute. Now, the next question is, what about drug treatment for NASH? And unfortunately, there are not a lot of great treatments. In fact, there are no approved drug treatments specifically for NASH. Vitamin E has shown some promise, and pioglitazone or insulin sensitizers have also shown some promise, and I'll tell you a little bit more about that in a second. First, back to weight loss surgery. So this is a relatively small study by Dixon et al. With 36 patients. And these are patients that had bariatric surgery for weight loss, and then they had biopsies of their liver. These were people with baseline fatty liver. They had biopsies of their liver both before and about 2 years after their weight loss surgery. And what they saw is that ALT went down after those 2 years. 91% of the patients had an improvement in their NASH, and 70% even had an improvement in fibrosis. So these actually are, pretty striking results, but a small population. And again, this is only over the course of 2 years of follow-up. Now, in people living with HIV, what about modifying their antiretroviral therapy? I've mentioned a couple of times that NNRTIs can increase risk of fatty liver. So this was a study by Macias et al. In CID, where they looked at some HIV patients with fatty liver disease. And they either switched, and these were patients who were already on efavirenz. They either switched their efavirenz to raltegravir, an integrase inhibitor, or they continued the patients on efavirenz. And so this graph shows what happened to the amount of fat in their liver over time. So the dashed line are the patients that were left on efavirenz. So you can see that their fat accumulation in their liver continued over the year follow-up of the study. Whereas the patients that switched to raltegravir, the amount of fat in their liver gradually fell over time. So ultimately, after a year, there was a significant difference in the amount of fat in the liver of the people who either remained on efavirenz or switched to raltegravir. So this is fairly good evidence, along with these other studies I've mentioned, that in patients with fatty liver, you probably are better off to have them on an integrase inhibitor rather than an NNRTI. So if you've had a patient, that maybe has been on efavirenz for a long time and has no trouble with it and likes it, but they have fatty liver, probably a good time to go ahead and switch to an integrase inhibitor. Interestingly, in this trial, there was no change in triglycerides, cholesterol, LDL, HDL, but nevertheless, the change in fatty infiltration in the liver. The PIVENS trial was a trial that looked at vitamin E and pioglitazone versus placebo. Notably, this was in HIV-negative patients. It was a large randomized controlled trial. And what they saw was that vitamin E treatment was superior to placebo in reducing liver inflammation and fatty infiltration over time. Pioglitazone actually did not show a significant benefit relative to placebo. There was a trend toward improvement in the pioglitazone arm, but it did not meet the designated endpoint of the trial. So the last drug I'm going to talk about is a drug that was tested specifically in people with HIV. It's called tesamorelin, and many of you may have heard of it because it's already approved to treat lipodystrophy in patients with HIV. It's a growth hormone releasing hormone analog. So this was a study to see what its effect was on NASH. It was a placebo-controlled double-blind multi-center trial where they took 60 HIV-infected patients with steatosis and randomized them either to receive tesamorelin for a year or to receive placebo. And what they saw was the tesamorelin arm had significantly reduced liver fat, which is shown here, compared to placebo. They also saw, and in a significant proportion of the patients, they even saw resolution of steatosis. In the patients that had elevated ALT at baseline in the trial, so these are the patients that had NASH, they did also see a significant improvement in ALT with tesamorelin. And interestingly, in the patients that had reductions in their LFTs, those reductions were sustained for 6 months, even after the patients stopped taking the tesamorelin. So some sustained effect. And finally, there was a reduction in progression of fibrosis in the patients that received tesamorelin. So in the tesamorelin arm, 10% of the patients had progression of fibrosis over the year of the study, whereas in the placebo arm, about a third of the patients had progression of fibrosis over a year. So that, is again a trial that shows some promise, but without long-term follow-up and of course, a growth hormone releasing hormone analog also has a risk of long-term side effects, including possibly increased risk of cancer. So whether somebody could potentially be on this drug for a long period of time, I think is a very open question, and probably is the big limitation or concern for tesamorelin. So this slide is just to show that there are many drugs that are in development now for treatment of fatty liver and NASH. The outer ring is phase 1, phase 2, phase 3. Very few drugs have made it to phase 3 trials yet. But my expectation is that over the next few years, there may be many new drugs on the market for management of fatty liver. The fact that that vitamin treatment alone has shown some promise, and various other treatments that reduce liver fat have shown promise, makes me think that one of these many drugs may eventually work out. And I'm very hopeful that that'll happen soon, because again, this is a huge sort of iceberg of a problem that's just lurking below the surface for our patients. So to come back to the case presentation, again, this is a gentleman that has elevated liver enzymes despite cured HCV. He already has advanced fibrosis by FibroScan prior to his Hep C treatment. He's on an efavirenz containing HIV regimen. So really, these are all correct answers. So it makes sense to order a CT of the abdomen in this gentleman. And the reason it makes sense is this would give you a VAT measurement, visceral adipose tissue. And I've shown you that is the best predictor in the general population and people living with HIV. It's the best predictor of whether people at baseline are going to have fibrosis from fatty liver, and the best predictor of whether they're going to have progression of fibrosis. You definitely want to do either B or C because the FibroScan with CAP or the MRI with PDFF is going to confirm whether this patient really does have fatty infiltration of their liver, whether they have fatty liver at all. It would definitely not be wrong to get a liver biopsy in this patient, because this is somebody that you already know had advanced fibrosis prior to Hep C treatment. So again, the thing that the liver biopsy will tell you more than any of the other tests is how much ongoing inflammation there is in the liver along with the fat. And it'll tell you whether there's a lot of ongoing hepatocyte damage in the liver. And finally, in a patient that already has fairly advanced fibrosis that still has elevated ALT, let's say we get the FibroScan and it shows that they do have fatty liver. This is a patient that's at very high risk for advancement of their fibrosis, development of cirrhosis. So I think that in this case, getting a hepatologist involved early is probably a good idea. And the last point that I'll make is that switching this patient from his efavirenz containing regimen to an integrase inhibitor is probably the quickest and best intervention that you can make, along with encouraging them very, very strongly to lose weight. So in summary, non-alcoholic fatty liver disease is very common, including in people living with HIV. There is no ideal diagnostic, so screening is currently not recommended. The workup that I've described generally would follow patients that have unexplained elevated liver enzymes, not just in someone who is obese, for example. We definitely need to stay vigilant in patients with metabolic risk factors and think about NASH if they have elevated liver enzymes. Lifestyle modification is the key intervention for treatment, and it actually does work if patients can lose weight. That, of course, is easier said than done. There's no approved drug treatment, but vitamin E has shown promise in non-diabetic patients. And there are many drugs in the development pipeline. So with that, I would like to thank my colleagues in the Johns Hopkins Viral Hepatitis Center, specifically Mark Solkowski, for many helpful discussions and some of the slides that I showed today, David Thomas, and also Ken Sherman at the University of Cincinnati, who also contributed some of the slides that I showed today. So with that, I would be happy to take any questions.
Muchas gracias, doctor Bailey, por su excelente presentación y tenemos tiempo para algunas preguntas. ¿Hay algún factor pronóstico asociado al diagnóstico de VIH con el riesgo de presentar hígado graso?
I'm sorry, could you say that one more time?
¿Hay algún factor pronóstico asociado al VIH, por ejemplo, carga viral y CD4 con el riesgo de presentar hígado graso en el tiempo?
Not that I'm aware of. HIV in general is associated with increased risk, and I think that long-term uncontrolled HIV certainly would lead to an increased inflammatory state in general. So I would not be surprised if patients with long-term uncontrolled HIV would be at increased risk. But I have not seen that specific study. Probably probably the strongest association, though, again, is with visceral adiposity, visceral fat, because that seems to be directly correlated with fatty infiltration in the liver.
Ok. En su experiencia, ¿cuál es el nivel normal de ALT para poder definir elevación de este parámetro y sospechar hígado graso?
Yeah, it's tough because the elevations are not really very high. So I would use a cutoff of 2 times the upper limit of normal as abnormal, and certainly over the course of multiple checks to make sure it's not just a transient abnormality. One thing I'll mention about that patient that I didn't mention before, he actually had a very good improvement in his liver enzymes after we had done his workup. He did have fatty liver on FibroScan. And it turned out that the big intervention was he stopped drinking alcohol. So he was not a heavy drinker by strict definitions. But nevertheless, when he stopped drinking alcohol altogether, his liver enzymes did improve. And time will tell whether his fatty infiltration improves as well.
Ok. ¿Y qué tan adecuado es el uso de ultrasonido para detectar hígado graso si no tenemos disponible elastografía?
I think it's not very useful, frankly. I think
Ok.
Yeah.
Y otra pregunta, ¿recomienda iniciar vitamina E en pacientes con VIH al detectar elevación de ALT, aunque esta elevación no sea considerable?
No. So what I would recommend is to pursue the workup to try to make a diagnosis of whether the patient has NASH or not. And only if the patient had NASH with evidence of fibrosis as well would I start to consider a trial of vitamin E. But that's only with a confirmed diagnosis and also with evidence of, I would say, Medivir 2 or 3 fibrosis.
Ok. Ok. ¿Y usted recomienda el tamizaje de hepatocarcinoma en pacientes con NASH?
No, the evidence to screen for HCC is only in patients with cirrhosis. So that could be cirrhosis caused by NASH, but there's no recommendation to screen in patients with NASH who do not have cirrhosis.
Ok. Ok, pues me parece que ya no hay más preguntas. Pues agradecemos muchísimo su participación en este simposio virtual de AMMVI. Y pues bueno, desde aquí reciba un abrazo y un agradecimiento por su participación y esperemos, bueno, nos vemos en su siguiente participación dentro de nuestro simposio. Muchas gracias.
Thank you.